sign or EKG differences. In the 2 years since our last meeting, 3 randomized controlled trials have been published. Now, 2 of them, you might say, well, that's old hat. It's basically the double-blind randomized fixed dose of extended release clonidine and the double-blind randomized dose optimization study with guanfacine XR. And then there was also a crossover study comparing methylphenidate transdermal to placebo transdermal. And you're probably familiar with those studies. The fixed dose study of clonidine XR was a little bit smaller sample size, 236. These are multi-site studies. And the doses assessed were 0.2 or 0.4 milligrams per day versus placebo, with a report of significant ADHD symptom improvement with effect sizes 0.71 at 0.2 milligrams and 0.77 at 0.4 milligrams per day. And we can visually see separation against placebo. In terms of the safety, 19% discontinued because of adverse events in the 0.4 milligram group, which seems quite a bit higher than the 7% in the 0.2 milligrams and the 1% in the placebo group. No serious adverse events, and the most common side effects, somnolence and fatigue. And please note bradycardia in 21% of those randomized to the 0.4 milligram per day group. And that estimate was 5 to 6% in the 0.2 or placebo group. For the dose optimization study for guanfacine, 217 participants, 6 to 12-year-olds. And here, the dose could range from 1 to 4 milligrams per day versus placebo. Also reporting significant symptom improvement for ODD, that was one of their outcomes of interest. And for overall ADHD symptoms, effect size 0.92. So smaller effect size for ODD and for ADHD. And we see from a safety perspective, 10% discontinuing regarding adverse events in the drug-exposed group versus 1% in placebo, no SAEs, and again, most common somnolence, sedation, and bradycardia, 5% in those randomized to drug, 1% in placebo. And similarly, they may have reported on differential effectiveness, but I'm showing here the overall separations of symptoms for overall ADHD symptomatology. And then in the Weiland study, this is a very small sample size, 30, 6 to 12-year-olds. They either received 10 or 20 milligram patches or a placebo patch with a significantly greater reduction of ADHD symptoms on the methylphenidate patch. What they also wanted to do is examine whether you had symptom reduction before school. The patch was applied very early in the morning. So this was not like kiss the child goodbye and put the patch on the way out the door. They put the patch on early in the morning, and then they still had time to be at home. And what I'm showing you here is they had developed as what they called their ADHD AM rating scale, which didn't have particular validation data, kind of has face validity. And you can see that for the methylphenidate patch, you had a larger symptom reduction for the placebo patch. Safety, 6% discontinuation because of AEs for those that had the active patch, and no SAEs. And again, the expected stimulant side effects, loss of appetite, GI upset, insomnia. And that brings us to the little bit more novel area here, combined treatment studies. So they're basically, we have 2 studies that look at participants that had suboptimal partial stimulant response, that continued their existing stimulant treatment, and then had measurement of kind of the usual suspects, ADHD rating scale, CGI, S series, and safety assessments. And there are 2 studies. One of them is a study that looked at extended release clonidine and uses a dose optimization approach, which we have already earlier heard, that really tends to give you better effects, better effect sizes, 0.1 to 0.4 milligrams per day. And the comparison would be continuing your stimulant and receiving a placebo. And in the group that was randomized to receive their stimulant and clonidine, significantly greater ADHD symptom reduction with an effect size of 0.34. And this is basically in somebody who already had this partial response to their stimulant. We can see that by adding on the alpha agonist, you could observe effects really quite quickly, separation already statistically significant at week 2. And in the Weiland study, also a dose optimization, except for they used the guanfacine XR 1 to 4 milligrams. And here, there was also a design feature that this was also given in the morning or in the evening. So I thought that was also a worthwhile additional piece of information, because we certainly clinically see that adding on the alpha agonists in the evening rather than in the morning. Sample size larger, 455, 6 to 17-year-olds, and randomized in a similar fashion, except for here you see 3 samples. So this would be AM, PM, and placebo. And you see a significantly greater ADHD symptom reduction, effect size 0.38 for the AM condition and 0.45 for the PM condition. Their picture a little bit more intricate, because you now have 3 arms, but we can see the separation happening is already, I think, at week 3, and maintains through the dose maintenance part of the study. So in both studies, we found similar safety reports. In both, less than 4% discontinued because of AEs. I thought that was important for us because that's kind of new. So the discontinuation rates because of AEs, 4%, seem respectably lower than what we had seen with the alpha agonist groups by themselves. We get reports of small decreases in diastolic and systolic blood pressure in those randomized to the alpha-2 agonists and stimulants. And we see somnolence, fatigue, sedation more common in those randomized to alpha-2 agonists, but really perhaps at a lower rate than if they are in monotherapy. This could be one example where this combined therapy actually results in fewer unwanted side effects. Now, both have similar limitations, short-term evaluation. The stimulant treatment wasn't necessarily optimized. And why is the placebo response so strong? Well, it may be that if you're in a study and you come in and you get monitored, that you just have a better compliance pattern than what you might see, so that you get an artificial increase in estimating what the placebo really does for you under those circumstances. But I think this we really need to consider as we update the stimulant guidelines, these findings. The one open label study that I did want to report on was a randomized open label parallel group, a dose ranging multi-center trial of molindone immediate release for children with ADHD and severe conduct problems. So here, 78 children were randomized, 55 completed. They went through 2 to 5 weeks titration, and then 6 weeks of treatment and 4 days of follow-up. They had 4 dose levels and were stratified by weight. Were they below or above 30 kilogram body weight? They also maintained their concurrent stimulant treatment and had primary, secondary outcomes as you might expect, had AEs as you might expect, somnolence, weight increase, akathisia, sedation, and the AEs increased with increased dose. During this short, relatively short follow-up period, no meaningful lab, vital sign, PE, or EKG changes, and improvement on conduct symptoms, CGI, and SNAP, and of course, open label, non-blinded short-term study.